When you decide to renovate a house, you usually assume the walls are just walls. Look, you strip back the wallpaper, and you fully expect to find standard, everyday drywall underneath.
Right, yeah. I mean, it's the foundational building block. Any contractor walking in knows exactly how to work with it, how to cut it, how to patch it.
Exactly. But what if you peel back that paper and find out the previous owner tried to, I don't know, reinforce the walls by injecting them with an industrial-grade glue?
Oh, wow. Yeah, that would completely change the game.
Right. Suddenly your basic everyday renovation is an absolute nightmare. The materials just don't behave the way they should. Your saw gets stuck, the wall crumbles instead of cutting cleanly, and the whole structural integrity is just a mystery.
It's a complete mess.
Welcome to this deep dive. Today our mission is to unpack a highly specific, honestly incredibly complex medical crossroad for you. We're looking at what actually happens when you switch from using energy-based vaginal rejuvenation treatments, things like lasers or radiofrequency, to seeking structural pelvic surgery.
It is a truly fascinating and, well, quite an urgent biological puzzle right now. We are pulling back the curtain on a really wide wealth of clinical literature today for you.
Yeah, we've got some heavy hitters.
We do. We're looking at specific clinical guidelines from the National Institute for Health and Care Excellence, that's NICEC over in the UK. Plus, we have safety communications issued directly by the FDA alongside some very revealing medical case reports from actual surgeons operating on these exact patients.
And the reason this specific crossroad matters so much is that millions of women are currently seeking solutions for issues like genitourinary syndrome of menopause, commonly called GSM, as well as, vaginal dryness or a general feeling of laxity.
Right, and everywhere you look, energy devices are heavily marketed to these women as the ultimate quick fix.
Oh, totally. They are heavily branded as non-invasive, which, on the surface, sounds fantastic.
It sounds incredibly appealing, especially when the alternative might be a surgical intervention. The promise of, an outpatient 15-minute procedure, it's a really powerful draw.
But today, we want to explore the hidden physical legacy those non-invasive tools actually leave behind. We want to show you exactly how they fundamentally alter the landscape of your own biology and why that matters immensely if you ever need to go under the knife down the road. Because non-invasive doesn't necessarily mean non-altering.
Exactly. And to really grasp how these treatments complicate a future surgery, we kind of have to start at the cellular level. We need to look at what these energy-based devices or EBDs are actually doing to the tissue when they're applied.
Right.
In the clinical data, we are primarily looking at 3 types of technology. So that's CO2 lasers, ERYHG lasers, and radiofrequency devices.
See, before reading the medical literature for this, I honestly thought a laser was just a laser. But the biological mechanics are quite different depending on the specific device.
Oh, very different, yeah.
For instance, ERYHG stands for erbium-doped yttrium aluminum garnet. And the reason that matters is because of how it interacts with water.
Right. Yeah, that's a crucial distinction. So ERYHG lasers are highly absorbed by water. And since vaginal mucosal tissue is very water dense, the ERYHG laser energy is absorbed incredibly quickly right at the surface.
Okay.
It essentially vaporizes the superficial cells without penetrating too deeply, which causes the surface to peel and regenerate. CO2 lasers, on the other hand, use carbon dioxide gas to create a beam that penetrates slightly deeper.
And that creates a different kind of injury.
Right. It creates tiny, fractionated columns of thermal ablation. Basically, microscopic burn, holes deep into the tissue.
And then radiofrequency, or RF, isn't using light at all, right? It uses electrical currents.
Exactly. RF uses the natural resistance of your own tissue to generate heat. It's actually similar to how a wire in a toaster heats up when electricity encounters resistance.
Oh, okay, that makes sense.
Yeah, so this allows RF to heat the deeper connective tissues in a bulk manner without actually breaking the mucosal surface layer at all.
But regardless of the delivery method, whether it's the superficial peeling of the RYA, the deep microchannels of the CO2, or the bulk heating of RF, the underlying physiological goal is identical.
Yes.
The medical term is controlled thermal injury.
Yeah.
Like you are intentionally damaging the tissue to trigger a healing response.
You're really trying to force the body into an acute inflammatory state. The heat causes the existing collagen fibers to contract and tighten immediately.
Just immediately shrinking up.
Right. And then over the next few weeks, the body rushes blood, oxygen, and fibroblasts to the area to lay down brand new collagen.
It's almost like if you've ever aerated a lawn, like you drive those heavy spiked rollers over the grass, punching thousands of little holes into the dirt. You're damaging the lawn on purpose to let air and water in, basically tricking the roots into growing back thicker and healthier.
Yeah, aerating is a really helpful way to visualize those micro-injuries, especially with a fractionated CO2 laser. Though mechanically, unlike a lawn, the vaginal wall is highly stratified. We are specifically targeting the lamina propria, which is the delicate layer of connective tissue just beneath the surface lining.
Right.
And to be fair, to be clear, for certain conditions, the clinical data confirms this controlled thermal injury can be highly effective.
Right, I was reading about women suffering from GSM. When estrogen levels drop during menopause, the vaginal tissues naturally thin out, they become dry, and they lose their elasticity.
And for women who are breast cancer survivors, this is a massive quality of life issue. They often cannot safely use topical estrogen therapies because their cancers might be hormone receptor positive.
Right, the hormones are a risk.
Exactly. So for them, a localized treatment that mechanically stimulates blood flow and moisture without introducing systemic hormones, it can significantly reduce burning and pain during intercourse.
But there's a massive biological catch here. These devices are only working on the mucosal surface layer. So the benefits are entirely temporary.
Yes, very temporary.
The clinical protocols we looked at generally advise, like 3 initial sessions. But the new collagen degrades. You have to go back for maintenance treatments every 12 to 18 months.
And beyond the temporary nature of the fix, we run into a hard mechanical limit. Lasers and radiofrequencies simply cannot fix structural mechanical failure.
Meaning, if a patient has a prolapsed organ, let's say the ligaments have weakened and the bladder is physically bulging down into the vaginal canal, a surface-level laser isn't going to pull a heavy organ back into place.
No, it's biologically impossible. Heating the superficial skin to generate a millimeter of fresh collagen will not rebuild the foundational fascial support that holds your pelvic organs suspended.
Because of that hard biological limit, patients eventually hit a wall. They might start with a laser, hoping for a quick, non-invasive fix for a feeling of looseness or heaviness. But eventually they realize the rejuvenation isn't solving the underlying structural problem. And that exact frustration is what brings us to the core of this deep dive. The transition from energy devices to the operating room.
Right. When symptom management fails, a patient realizes they need an actual structural repair. For pelvic organ prolapse, which, by the way, affects about 1 in 10 women to the point of needing surgery, the standard intervention is a procedure called a colporrhaphy.
I was reading through the surgical descriptions of a colporrhaphy. It's considered a minimally invasive surgery, but the mechanics of it require incredible precision.
Absolutely.
The surgeon has to make an incision in the vaginal skin, carefully peel that mucosal layer away from the deeper connective tissue, the fascia, and then stitch that underlying fascia tightly together to push the bladder or rectum back up.
The key phrase there is carefully peel that mucosal layer away. Surgeons rely on natural, predictable planes of tissue dissection. Healthy tissue separates somewhat cleanly. It's kind of like peeling the skin off a ripe orange.
Right, it just gives way naturally. But before we get into what happens during that surgery, it's worth noting that the frustration of patients cycling through lasers without getting structural relief, that's exactly what triggered major regulatory bodies to step in.
Oh, definitely.
I was looking at the FDA safety communication from a few years ago, and they were incredibly blunt.
The FDA was reacting directly to a massive surge of aggressive marketing. Clinics were pushing these devices off-label, promising to cure vaginal laxity or even incontinence.
Which is wild.
It is, and it led to numerous reports of vaginal burns, scarring, and persistent pain. The FDA explicitly warned that these devices are cleared for cutting and coagulating tissue in standard surgeries. They are not cleared for broad, surface-level rejuvenation.
And the NICE-V guidelines in the UK completely echo that. They emphasize that the long-term evidence for using these devices for laxity or structural issues is practically non-existent.
Non-existent, exactly.
But let me play devil's advocate for a second here.
Okay, go for it.
Let's say a patient buys into the marketing anyway. She gets 3 rounds of radiofrequency or laser treatments. A year goes by and she realizes her laxity is actually a prolapse. So she just abandons the laser clinic and books a colporrhaphy with a surgeon instead. She just switches tracks. The laser didn't work, so she moves on to surgery. Why is that a problem? No harm, no foul, Right.
Well, because that assumes the surgical canvas is blank. It assumes the tissue simply reverted to its natural original state after the laser wore off, but the legacy of that controlled thermal injury fundamentally alters the microarchitecture of the vaginal wall.
I was looking through the clinical case reports we gathered, specifically to answer this exact question, and the surgical notes are really jarring.
They are.
Take the case of a 52-year-old perimenopausal woman. She had a mild vaginal bulge and feelings of looseness, so she went to a clinic and received a full course of fractionated CO2 laser treatments.
Okay.
A year later, still suffering from the bulge, she goes to a hospital for a posterior vaginal repair, a standard colporrhaphy.
Right. And when her surgeon made that initial incision and attempted to find that natural plane of dissection, we talked about trying to peel the mucosa away from the fascia like an orange. They couldn't do it.
Wow.
The surgical notes describe her vaginal mucosa as being rigid, scarred, and difficult to dissect.
It's like if you're a tailor and you're hired to alter a beautiful, delicate silk dress, but the previous owner ironed the dress on the wrong setting. The silk has literally melted into the lining. It's stiff. It's brittle.
That's a great analogy.
You try to put a needle through it or separate the seams and the fabric just shreds. It doesn't behave like silk anymore.
That is a highly accurate representation of what the surgeon is facing at a microscopic level. When thermal stimulation is pushed just slightly too far, whether because the device settings were too high, the treatments were too frequent, or even just the patient's individual biology was sensitive, that micro-injury tips over into fibrosis.
And fibrosis being the medical term for dense scar tissue.
Yes. Instead of laying down bouncy, organized collagen fibers, the body panics and lays down rigid, disorganized, cross-linked scar tissue.
It just glues everything together.
Exactly. That fibrosis essentially glues the layers of the vaginal wall together. The natural sliding planes are completely obliterated, so when a surgeon tries to separate them, they have to use sharp dissection.
Which means using a scalpel or scissors instead of just gently separating it.
Right. They are literally scraping and cutting the layers apart blindly, which dramatically increases the risk of accidentally slicing into the rectum or the bladder.
Which turns a standard safe operation into something much longer, much bloodier, and vastly more dangerous. And the second case report we reviewed highlights a completely different but equally dangerous biological reaction.
Yes, the 39-year-old.
Right. This is a 39-year-old premenopausal woman. She had laser treatments for laxity and stress urinary incontinence.
And a year later, she required a posterior repair for a prolapse and a mid-urethral sling to actually treat the incontinence. But during the procedure, her surgeon noted that her tissue wasn't just rigid, it was very thin, friable, with a complete loss of rugae.
To clarify those terms for you listening, friable basically means the tissue is so fragile it crumbles or tears easily under the slightest pressure. And rugae are the natural folds and ridges inside the vaginal wall that allow it to stretch and expand like an accordion.
Right, so losing those rugae means losing the inherent elasticity of the organ. And having friable tissue means that when the surgeon tries to place a suture to hold the prolapse repair together, the stitch just tears right through the tissue like wet paper.
Oh, that sounds like a nightmare for the surgeon.
For this 39-year-old patient, the operation was extraordinarily difficult and resulted in significantly higher blood loss simply because the tissue had lost its structural integrity.
It's wild to think that a 15-minute, heavily marketed outpatient procedure can leave a permanent microscopic footprint that actively jeopardizes a major structural surgery years down the line.
This is exactly why the sequence of treatments is dominating the conversation in urogynecology right now. Understanding the chronological roadmap of a patient's interventions isn't just taking a history, it's a matter of surgical safety.
Now, we've been focusing on what happens when you go from laser to surgery, but the medical literature makes it very clear that navigating the reverse sequence, going from a structural surgery to an energy device, carries its own set of severe biological risks.
Oh, absolutely. Particularly when we introduce synthetic materials into the equation. Let's look at the pelvic mesh scenario.
Okay.
If a patient has previously undergone a surgical repair that utilized synthetic pelvic mesh to suspend a prolapsed organ, their anatomy is permanently altered. There is a foreign body integrated into their connective tissue.
So what happens if a practitioner at a medical spa who might not fully understand that surgical history inserts a radiofrequency probe and starts bulk heating that tissue?
The mechanism of injury here is severe. We mentioned earlier that RF uses tissue resistance to generate heat. Synthetic mesh and the dense scar tissue surrounding it have entirely different electrical resistance profiles compared to healthy mucosa.
Oh, I see where this is going.
Yeah, when you apply an electrical current, the energy can concentrate around the mesh, creating thermal hotspots.
Which leads to localized inflammation directly over the surgical site.
Exactly. And that inflammation can cause the overlying mucosal tissue to thin out and break down, leading to mesh exposure.
Oh, wow.
Yeah, the synthetic mesh literally erodes through the vaginal wall, exposing the rough material to the open canal. It causes excruciating chronic pain and almost always requires another highly complex surgery to remove the exposed mesh.
That is terrifying. The clinical guidelines from NICE are incredibly strict about this exact scenario. They mandate that a specialist-aware review of any prior surgical repair, especially those involving mesh, is an absolute prerequisite before an energy device can even be considered.
You really cannot just walk in and get a laser if you have hardware in your pelvic floor.
And NICE goes even further. Their foundational guidance for dealing with any pelvic floor dysfunction, whether it's prolapse, laxity, or incontinence, mandates a strategy of conservative care first,
Right.
meaning you exhaust every truly non-invasive option before permanently altering the tissue. You start with targeted pelvic floor muscle training, supervised physiotherapy, and lifestyle modifications.
You do not jump straight to lasers, and you certainly don't jump straight to surgery.
But, reading through all of these warnings about overtreatment and the dangers of misusing a surface-level laser on a structural prolapse, it raised a massive question for me about diagnostic accuracy.
How so?
Well, if a woman walks into a clinic and says, I feel a sensation of heaviness, or I feel loose, and the clinic just hands her a pamphlet for a laser package, how do they actually know what they are treating? I mean, laxity is a highly subjective symptom, right?
It is entirely subjective, yes. And diagnosing it solely based on patient sensation is a recipe for clinical failure. The feeling of looseness or a lack of friction can be caused by a myriad of complex biomechanical and neurological issues that have absolutely nothing to do with needing a laser or a surgical repair.
I was honestly shocked to learn what some of those other causes are. For instance, the feeling of looseness can actually be caused by the exact opposite mechanical problem, a hypertonic pelvic floor.
Right. A hypertonic pelvic floor means the muscles are in a constant state of spasm or are overly tight. When a muscle is constantly clenched, it inevitably fatigues.
Makes sense.
And when those pelvic muscles fatigue, they lose their ability to dynamically support the vaginal walls during movement. The brain interprets that lack of dynamic support as a feeling of heaviness or looseness.
So if a practitioner aims a thermal laser at a hypertonic pelvic floor, thinking they need to tighten loose tissue, they are basically burning a muscle that is already screaming in a spasm.
Exactly. It won't fix the looseness. It will likely just amplify the pelvic pain.
Just adding fuel to the fire.
To build on that, another frequent misdiagnosis involves neurological trauma. If the pudendal nerve is stretched or compressed during a difficult vaginal delivery, it can result in a significant loss of sensory feedback.
So the physical architecture of the vagina might be perfectly normal, but because the nerve isn't transmitting the signals, the patient perceives a lack of sensation as physical looseness.
Right.
And obviously a CO2 laser, vaporizing the surface mucosa, isn't going to heal a stretched pudendal nerve deep in the pelvis.
No, not at all. Nor will an energy device fix the mechanical geometry altered by a perineal scar. If a patient had an episiotomy or a severe tear during childbirth, the scar tissue at the vaginal entrance can tether the skin, pulling it into an asymmetrical shape that feels physically open.
And a laser won't release a mechanical tether.
Precisely. This is why a comprehensive physical assessment by a specialized pelvic floor physiotherapist or a urogynecologist is mandatory. You cannot effectively treat a subjective symptom without isolating the precise biological source.
It really is like noticing a crack in your living room wall and just slapping a thick coat of paint over it, expecting the house to stop settling. It just completely ignores the root cause.
And it makes things worse.
Right. Even worse, as we've seen from these surgical case reports, that paint might actually glue the drywall to the studs, making it completely impossible for the structural engineers to actually fix your foundation safely a year later.
That is the perfect encapsulation of the clinical risk here. The interventions we choose today rewrite the anatomical canvas for tomorrow.
So, to bring all of these clinical guidelines, surgical reports, and biological mechanics together for you listening, the primary takeaway from this deep dive is a necessary reality check on the phrase, minimally invasive.
A very necessary reality check.
When it comes to energy-based devices like lasers and radio frequency being used in the vaginal canal, non-invasive absolutely does not mean non-altering.
That is the critical distinction patients really need to understand.
These devices are powerful biological tools. They're proven to be effective for very specific surface-level mucosal issues like managing the severe dryness and pain associated with menopause or estrogen deprivation from breast cancer treatments.
Yes.
But they work by fundamentally changing the cellular biology of your tissues. And if you ever hit the ceiling of what those surface treatments can achieve, and you eventually require a structural surgery, like a colporrhaphy, to repair a pelvic organ prolapse, you need to go into that operating room knowing that your tissue has been permanently rewritten.
It has.
The physical roadmap your surgeon relies on has changed.
It absolutely has. The natural surgical planes may be completely obliterated by microscopic fibrosis, and the tissue integrity may be severely compromised. And looking at the broader trajectory of modern medical technology, this leaves us with a rather provocative thought to ponder.
Oh, where is all of this heading?
Well, if these heavily marketed, widely adopted energy-based therapies routinely leave behind an invisible footprint of fibrosis that severely complicates basic structural surgeries, we have to ask, are we fundamentally redefining what minimally invasive actually means?
Oh, wow.
By seeking these quick fixes, we are rapidly creating an entire demographic with iatrogenic or treatment-caused tissue alterations. Down the line, as millions of women who utilize these devices age and inevitably require structural prolapse repairs, will the medical community be forced to invent entirely new surgical tools and techniques just to cut safely through a whole generation of rejuvenated tissue?
Wow. Are we just building a harder, more complex wall that the next surgeon has to figure out how to break down safely?
It really looks that way.
So the next time you hear an ad promising a quick, painless, non-invasive rejuvenation, remember what might be happening to the drywall underneath the wallpaper. It might look beautifully smooth on the surface, but you could be changing your foundation forever. Thanks for joining us on this deep dive. We'll catch you next time.